right. So what am I going to be talking about? So I'm talking about what is oncology. Why are my patients so different? They're difficult patients. They're not difficult. They're lovely people. But they are lovely people who come to me with a problem. And that problem is they've already got a nasty illness, which left untreated will kill them. And then I do even more horrible things to them. And those horrible things put them at risk of infections. So I'm a solid tumour oncologist. I'm not a haematologist. I apologise if there's any haematologists in the room, and I apologise if there's any paediatric oncologists in the room. I know nothing. I'm simply a solid tumour oncologist. What's oncology? Well, cancer. It's cells that keep on dividing when they really shouldn't do, and they spread to places they shouldn't be, and they start to invade organs, and they start to cause all kinds of problems. And those problems are mostly that they get into the bone marrow. Bone marrow is where our white cells are made. Our white cells are what fights infection. And then I do horrible things to them. Obviously, the reason that we're here is to talk about antimicrobial stewardship. It's really important. I've done horrible things to my patients, and then on top of that, I make them immunosuppressed, and then they get an infection, and then actually I look at Gemma and I go, actually, my deep prescribing pharmacist, please could you help me on the ward because this person has had 2 weeks worth of Tazocin and their temperature's still 39. What am I doing wrong? So we've talked briefly about this. I'm not going to repeat myself, but cancer, bad things, left untreated, it kills people, and the way that it kills people is by basically making their organs fail. It makes them very, very thin, very frail. That puts them at even more risk at catching infections, even if I'm not doing anything horrible and suppressing their bone marrow. And they get blood clots, and that probably doesn't have any significant impact on infection, but as soon as you've got an infected bit of lung, there's going to be some kind of bug that wants to take hold there. So every specialism thinks that they're the best specialist, and obviously I love oncology. As you can see, I get quite excited. But the things that I'm treating are pretty miserable. They make patients really poorly. Cancer gets into other parts of the body. It gets into different areas. It causes holes. It causes all kinds of problems. Now, haematology, I'm sorry, I've put a sentence in here because that's what's needed. So my cancer, some of my patients, and I have to say myself and Gemma predominantly treat gynecological cancers, and the majority of those present at a late stage and the patients have already got advanced disease. But a significant proportion of people come to us actually in a curative setting. They've had a cancer. A very friendly surgeon up the road has taken that cancer out. They've recovered relatively well from the surgery, and then they come to us because we want to just make sure it doesn't come back again, so we do other stuff to them. Hematological malignancies, unfortunately, are by definition pretty much systemic. It's everywhere in the body before you even get started on anything. Just out of interest, I'm looking out the window. I'm very easily distracted. There is a balloon flying past, just in case anybody wants to see something pretty. Totally not related. I'm sorry, I will keep talking until the cows come home. Please tell me to stop. So the problem, really, the reason that I'm here, is that what I spent yesterday doing, Gemma spent yesterday doing, was seeing people with nasty illnesses, most of whom are not in the curative setting, and then saying to them, hi, would you like to sign a piece of paper to have some treatment? It's going to make you feel pretty rough. You're going to feel sick. You can be really tired. And then, oh, by the way, about 5 to 7 days into treatment, your immune system's going to go like that. And then if you get a bit of a temperature, we want you to call us anytime, night or day. So 3 o'clock in the morning, Sunday night. Don't just take a paracetamol, go to bed. Give us a call. And what happens when you give us a call? Well, we're going to tell you that you probably need to go into hospital. Sorry, A&E people. So, I've already kind of mentioned this. I'm very good at just chatting. What's the problem with cancer? Well, the surgeons cut a hole in you. So you're going to have a hole that's going to need to heal. There's going to be some wound healing issues. There's potentially going to be some infection. Oh dear, that again. We then want to give people chemotherapy. Oh God, they've had about 15 different types of chemotherapy. Their veins are absolutely dreadful. So what are we going to do? We're not going to put in a central line like they do in ITU and then have nurses really carefully look after that. No, we're going to put in a PICC line. So it goes in the top of your arm, just kind of at the crook of the elbow where there's lots of kind of it's nice and warm. And then we're going to send you home with it. Don't go in the bath, don't go swimming, but you're going to go home with it. District nurses will come out and check it and put the dressings on it. And then, oh, you've got prostate cancer. Oh, your prostate's a bit enlarged. We probably can't treat that. Oh, do you want a catheter? Go home with it. Oh dear, your cervix cancer has relapsed and you've got lots of masses in your abdomen and now one of your kidneys is blocked and actually you're otherwise all right. So you know what? We're going to put a nephrostomy and we're going to put a tube that comes out your back and we're going to send you home with it. And you've got head and neck cancer. We're going to give you some horrible radiotherapy. You're not going to be able to swallow for about 3 months. We'll put a tube in through your stomach, and then you're going to go home with it. And this probably people don't tend to go home very often with tracheostomies, but yeah. we do see people with tracheostomies coming into our hospital and having treatment. And then on top of all those things that we've put into you, we're going to give you some treatment that's going to completely smash your immune system, and you won't be able to do it. Yeah. And then actually, well, you've got this gastric cancer, and we're going to give you some treatment that causes really nasty acneiform rash. And you don't want to look like a spotty teenager, so here, have some doxycycline to take every day alongside it to prevent you getting a spotty rash. So all these horrible things. Why am I here? Because actually it causes all kinds of problems. We affect the bone marrow. We cause the neutrophil count to go down. The neutrophils are the most abundant white cell. They are the ones that fight predominantly the bacterial infections, which are the ones that we've been talking about for the majority of today. Some of our treatments affect the lymphocytes. We need them too. Actually, no lymphocytes, you end up with really nasty infections that just you can't clear them. And sometimes that's lifelong. Sometimes we do that and it's there forever. So we cause people to be at risk of developing bacterial infections, viral infections, fungal infections, everything. Probably not leptospira, got to say. Unlikely. I've not got any patients who live on a barge. But you never know. Usually in solid tumour oncology, that's transient. We give them the chemo 5 to 7 days. Blood counts go down. 5 to 7 days later, blood counts go back up again. Come back to clinic, we'll do it all over again. So cycles tend to be 3 or 4 weekly. In haematology, and again, don't even pretend to know what I'm talking about really, and the same will count for transplant people. We give them immunosuppressants and they have no immune system for a prolonged period of time, and that probably has a higher risk of developing weird pneumocystis type infections or fungal infections, which require a whole different type of treatment. But I'm going to focus predominantly on solid tumour oncology because that's what I know about. So we've given you your chemo 5 to 7 days after chemo. Oh, bit hot. Oh, my husband said I should probably take my temperature. Do I really want to do that? Okay, fine. Stick the thing under my tongue. Oh, 38 degrees. I'm sure my little card told me I needed to come in and do something. So phone the 24-hour helpline. Now there's a national organisation called UCONS, and they have developed a national triage tool. And that national triage tool will recommend that if your temperature is above 38, you need to go into hospital to be seen. Well, I work in a tertiary oncology centre. We haven't got an A&E. We've got a few assessment unit beds, and if you come in on a Tuesday afternoon, then fine, we'll deal with it. But actually, most of the time, the patients are going to be sent to A&E. Well, you guys are already insanely busy. And how are you going to know that my patient is a priority? Because there's quite a high possibility they haven't got any neutrophils and they are going to succumb to sepsis pretty quickly. So sepsis in neutropenia is really nasty. Mortality is up to 40%, probably more, if you are high risk. Now, we have lovely risk scoring tools, something called the MASK score. Now, this is really important for antimicrobial stewardship because it will, if we use it well, help us to decide which people actually need those intravenous antibiotics and which people, maybe we don't need to do that. So, it's a very busy slide, I'm really sorry. People come in, they've got a temperature, they might be neutropenic. Now, our hospital has a lab, it takes probably about 45 minutes to get a full blood count back. But you don't want to be waiting your 45 minutes in your hour door to needle time to actually get your antibiotics in. So, people will always have a dose of broad spectrum antibiotics because that's what the guidelines say we should be doing. We can work out whether or not they need a second dose by doing a MASK score. And if they are neutropenic, this is not for people who are not neutropenic. If they're not neutropenic, they just go on to a standard, do you have sepsis pathway, and we stop panicking. But if you are neutropenic, and by neutropenia, so I'll go back to the previous slide, it's neutrophils of less than 0.5, which is actually quite significant neutropenia. Neutropenia really is neutrophils of 1.1, but I don't get too bothered about that. I prescribed somebody's chemotherapy yesterday for their next dose with neutrophils of 1.1. I know they're going to drop further, but there we go. I'm used to it. Doesn't freak me out. Freaks other people out. So if you score quite highly on this, and this is one of those scoring systems where high is good, low is bad. If you score highly and you don't have a particularly high burden of symptoms from your potential sepsis, then we can probably get away with just giving you some oral antibiotics. So you have your one dose of whatever the protocol says you need to have. And then actually, well, you're probably all right. You can probably go home. Length of stay is reduced. No admission needed. Actually, the amount of antibiotics given is far less. That's a good thing. But we're not commonly using this. We're using it in our centre, but not particularly consistent. And I'm not convinced that the rest of the world has quite cottoned onto this yet, because there's a fear. It's that risk aversion that was being spoken about earlier. We don't want to be putting our patients in harm's way. So we want to be careful, extra careful, because then neutropenic and it's scary. So 1 hour door-to-needle time, it's kind of internationally accepted that the quicker you treat somebody who potentially has sepsis, the better the outcome is going to be. But do we really need to give everybody broad-spectrum antibiotics? That is what the guidelines say. That is currently the NICE guidelines tell us that. The ESMO guidelines, which are the European Society for Medical Oncology, say that's what we should be doing. I don't know. It's always the right thing. So what's the problem? Well, we're giving everybody antibiotics. And there's local variation in what bugs are out there in the community and what people are going to potentially succumb to and what they might come in with. Now, I've put up a little map here. Myself and Gemma work all the way down here. We work in a tertiary centre. We don't have everybody come in to us. We also serve this area, and so our hospital is the tertiary centre within that geographical area. Got a population of about 1.1 million, but we've got 4 different health boards with 4 different policies, which means that there are different prescribing recommendations. So all of this results in basically what this next slide shows. Now, this was, thank you very much, Alicia. Thank you very much, Henry, for pointing this out to me. This only came out last month. Antimicrobial resistance in the organisms found in patients who are receiving cancer treatment, and this is a US study and a hematology study, so they don't necessarily completely relate to solid tumour oncology in the UK, is way, way higher than the background population. I know there's 101 things on there, but for every single organism that's mentioned in this list, it's worse if you've got cancer. Probably because every time you've had a vague temperature, we've given you some meropenem or some tazocin or some amikacin or whatever the protocol says we should be doing. It's probably not a good thing. So what are the possible solutions? Well, we use this thing called GCSF. It's pretty horrible. You give yourself an injection 24 hours after you've had your chemotherapy, boosts your white blood count by stimulating your bone marrow, makes everything hurt. All your bones, everywhere that your bone marrow is, will absolutely ache. You may have fevers. Oh God, you've had a fever. You've had GCSF. Your white count is probably about 50, but you've had a fever, so you better go in and have some antibiotics. So it's a bit of a problem. Point of care testing, well, bioMario's fantastic. It's coming up with all these really, really clever ideas. If we have them in our assessment unit, maybe we'll know before the white count even comes back from the lab whether or not this is a bacterial infection. Now, that's really useful because I haven't really talked about the fact that every single drug that we give, and there's about 100 different systemic anti-cancer treatments, somewhere in the fine print will have, it can cause myelosuppression. But we also use this stuff called immunotherapy that causes absolutely every part of the body to become inflamed. Potentially, not every single patient, otherwise we wouldn't give it. But they can develop colitis. So colitis, the leptospira patient. Bloody, mucousy, disgusting stuff coming from the back passage. Have they got leptospira or have they got immunotherapy-induced colitis? Well, the treatment's rather different. You give high-dose steroids for the colitis. Probably need some kind of weird antimicrobial for the leptospira. I don't know which one it is until I get some results back. I don't think point-of-care testing is quite going to help that. But then what we actually do and what we can do and what we are doing, and the reason that I have brought my deprescribing pharmacist along with me, is that actually really proactive antimicrobial stewardship, which is what we do in our centre, because I don't work by myself. I can't work by myself. I need my colleagues. Is actually we've got an antimicrobial stewardship team. And I'm going to hand over to Gemma at this point because she knows how that works and I just talk.
Okay, I'm going to try and keep it brief. So
sorry, I can't do that.
So this is just the definition of antimicrobial stewardship from NICE. I'm not going to go over this again because you're all going to know it. But what is important is that in the context of cancer, antimicrobial stewardship is really difficult because it is a fine balance between prudent antimicrobial use and treating what could be a life-threatening infection efficiently and effectively. So what do we do in practice? So I'd say there's 3 key things. The first 2 I'm going to go through very quickly. I'm not going to expand on them. Obviously, we have guidelines which are based on like local resistant patterns and things like that. We can use those. We can take cultures, hopefully before we give antibiotics, because that gives us our best chance of growing any organisms that are there. And those 2, after that point, we normally start. So if it was neutropenic sepsis, we'd start meropenem. But thirdly, and most importantly, probably is the rationalisation of antibiotics. So we essentially hopefully get those cultures back. That's good. But also we use an MDT. So we have a specialist antimicrobial pharmacist, which is me, apparently. We have a consultant microbiologist and IPC that join the normal weekly ward round, and this allows our resident doctors to ask us any questions. It builds up that sort of level of trust, so they're not scared to ask things either. We can advise on things such as the type of antibiotic, the dose, interactions, duration, all that sort of thing, counselling for patients. But also it kind of shares that responsibility of antimicrobial stewardship, and it fosters that in like a positive way. I think that really works because on our ward we do have a lot of patients who are complex and ill, and because we are a tertiary centre, as Amy's already said, we don't have an A&E, but we also don't have an ITU or an HDU. So if someone is unwell and they're at the point where we need extra help, we need to send them out, and we need to send them to somewhere more suitable as soon as possible. I think that's pretty much it. Would you like to expand?
I don't know that I have a huge amount to expand. Thank you very much. We're very nearly out of time. So I've got 2 more slides. So this is what Gemma has said. So our MDT, as Gemma has said, it works very well. We all speak to each other very regularly. We're very lucky. We're a really small centre, but really important. And this is something that came up before, and it's the reason I want to just point this slide out, is that this is a collaborative thing. This is shared responsibility amongst the clinicians who work in the hospital, but also the wider public. So there is a huge role to be played by people being aware of what sepsis is, what the risks are, how to contact the right people at the right time about this. And I think the media has a huge role to play. So in summary, I make my patients ill, and then Gemma makes them better.
Try to.
So antimicrobial stewardship, or however we want to phrase it, you can be my deprescribing pharmacy colleague if you wish, will hopefully help to preserve the antibiotics that we already have for future use. Thank you very much.
Thank you.